I'm Jesse Witkoff. I'm a pediatric dentist in Denver, Colorado. I've had a journey. I started off in my practice with an erbium YAG and treating frenectomies with a diode and the erbium. And it really left a lot to be desired. With the erbium YAG, there was still a lot of bleeding. It was very difficult to see, and it left them a little more painful afterwards. The diode also had its problems. It takes a lot longer, and it's using thermal energy, and so you're getting a little bit of a burn. Since using the CO2 laser now with light scalpel, my results have improved drastically. The amount of pain and discomfort afterwards is almost non-existent. It is just phenomenal, and the parents, are watching it as it happens, knowing that it's not going to hurt as it's being done. So I can't say enough about it. It has really set the basis and the foundation for my practice.
You're listening to the Tongue Tie Experts podcast, a weekly program providing information and support for those families impacted by tongue and lip tie and the professionals caring for them. I'm Lisa Paladino, a midwife and a lactation consultant with over 30 years of experience. If you are a parent looking for answers or a professional who is curious to learn more than what you learned in school on this topic, welcome. This podcast is for you. A gentle disclaimer. Please do not consider anything discussed on this podcast by myself or any guest of the podcast to be medical advice. The information is provided for educational purposes only and does not take the place of your own medical or lactation provider. Thank you. Welcome, everyone, to this week's episode of the Tongue Tie Experts podcast. I'm your host, Lisa Paladino, and today we're diving into an expert opinion and honest discussion of the American Academy of Pediatrics clinical report on the identification and management of ankyloglossia, also known as tongue tie, and its effect on breastfeeding infants. We're going to discuss this with openness and honesty because it's essential to think critically and avoid making knee-jerk reactions. There are definitely good points in this report, and we'll go over them. And I also have criticisms of their approach that need addressing. I also have criticism of the lack of respect and confusion regarding the field of lactation in general and IBCLCs specifically. There's quite a bit of misunderstanding in this report. It's revealed in this report. And I believe the AAP has created a self-fulfilling prophecy. In other words, if we practice the way they predict or suggest, we would get the results they anticipate. But there's more to the story that AAP does not know about. One general statement that I will make is that the AAP considers ankyloglossia or tongue tie to only affect breastfeeding. It also very often affects bottle feeding and feeding of solids. The other huge omission from this report is the mention of airway. Airway disorders, starting with inability to nose breathe, often start in infancy and can be related to tongue tie. There is a definite gap in understanding of airway issues which needs to be addressed and isn't in this document. But let's chat about what is addressed here. I reviewed the entire document and made notes about what I agreed with and what I didn't. So let's break it down point by point. One of the positives is their statement about exclusive breastfeeding for around 6 months, continuing up to 2 years, or as long as mutually desired by both mother and infant. That's excellent and fully aligned with what we promote in the lactation field. They also acknowledge that a team partnership is necessary, but we'll get into the details of that team later. They highlight the lack of consensus in treatment approaches, which is something we in the field are actively working on. For instance, the International Consortium of Ankylofrenula Professionals, also known as ICAP, has research and consensus building efforts underway, but there is still a long way to go. And I will include the references in the show notes, and the references are in the blog on my website. You can go to tonguetieexperts.net/blog for the references for more information on this. I link to ICAP. I link to the definition of IBCLC, and I link to the document that I'm reviewing there.
I am Scott Siegel. I am an oral and maxillofacial surgeon. I'm a physician as well as a dentist based in New York City. My practice is about 95% tethered oral tissues. Well, I've been using Light Scalpel since its inception. I've used its predecessor, Luxar. I've been using CO2s for 20 years, and it was a natural transition for when Light Scalpel, came out, took over, and I have not looked back. I have 3 Light Scalpels in my practice. My satisfaction rate's that's highest. That's why I have such a thriving practice at this point, because people actually seek out. They know the differences now, whether it's from social media or whatnot, what type of lasers are out there, and many of them will actually call asking if we have CO2 or using Light Scalpel. So that feedback out in the community is there in my area anyway, and so people do seek that out.
Here's something that I do agree with. In some cases, tongue tie is overdiagnosed. But I will argue it is also underdiagnosed. That sounds contradictory, but it's true. Some infants are being diagnosed and treated without the necessary care, while others who genuinely need treatment are being missed. The AAP report focuses heavily on the overdiagnosis side, but that doesn't negate the fact that many cases go unnoticed or untreated. This isn't an either-or situation. The report also dives into anatomy, and while they provide a decent discussion, they start nitpicking about terminology, like the term posterior tie. To me, that's not the most important issue. What matters is how we treat and support these babies and their families. One point that disappointed me was their reliance on outdated references. Some of the studies they cite are more than 15 years old. In my professional presentations, I'm often told not to use anything older than 5 years. They're looking at studies that are dinosaurs compared to the current research. I really wish they had explored more recent data, especially since our understanding of tongue tie and breastfeeding has evolved so much. The AAP goes on to define symptomatic ankyloglossia as an infant with a restrictive frenulum and breastfeeding difficulties not improved with quote-unquote lactation support. But how do they define lactation support? They don't. There's no detail about what kind of evaluation or support is needed, which leaves a lot of gaps in their recommendations. There is even one point where they say can be referred to a lactation specialist or a nurse in their office. Now, I don't know about you, but when I was a nurse, I didn't know so much about this. Until I became an IBCLC and then had further learning, I didn't know how to assess breastfeeding, and I certainly did not understand tongue tie. So I don't know what nurses they're talking about. Now let's talk about what they missed. the role of the IBCLC, International Board Certified Lactation Consultant. The report talks about lactation specialists in vague terms, but doesn't once specifically mention IBCLCs. This is a big omission. IBCLCs are the professionals most trained in clinical breastfeeding management, hands-on practice, and rigorous exams. Yet the AAP only briefly mentions lactation specialists without giving proper credit to those with the most expertise. Their algorithm on diagnosing and treating tongue tie suggests that the primary care provider should confirm the diagnosis and proceed to frenotomy if necessary. But where's the mention of lactation support before and after? Breastfeeding issues often require ongoing detailed care beyond a surgical release. One point in the report that really bothered me was their stance on research. The AAP claims that the only acceptable way to assess the effectiveness of frenotomy is through randomized controlled studies. While that's considered the gold standard, other types of research, like observational studies, still offer valuable insights. By dismissing other forms of research, the AAP overlooks so much important evidence and experience from clinicians in the field. I will say that again. By dismissing other forms of research, the AAP overlooks a lot of important evidence and experience from clinicians in the field. No other medical issue is held to this rigid standard, so why should tongue tie be held to this standard? The AAP's algorithm is also problematic. It emphasizes the role of pediatricians in diagnosing and treating tongue tie, but doesn't make room for IBCLCs or body workers like craniosacral therapists or other body workers. The report even goes so far as to call body work non-evidence-based and costly. This kind of thinking dismisses a whole range of therapies that could help avoid unnecessary surgical interventions or make surgical interventions more timely and more effective, and also increase healing and results after the surgical intervention. The team approach they talk about is incomplete and excludes important voices. Finally, the report criticizes social media, suggesting parents are being misled and that pediatricians should be cautious. Well, yes, not all information on social media is accurate. It also seems like they're undermining parents' instincts and knowledge. Parents are often the first to notice problems, and we need to trust and support them. The idea that parents can't make their own decisions based on information they find feels dismissive and patronizing. To wrap up, while there are some points in the report I can agree with, there are significant gaps, especially in how they treat IBCLCs and the broader healthcare team. We need a more holistic, collaborative approach to tongue tie treatment that includes lactation consultants, body workers, and other specialists. It's also essential to update the research they're relying on and to respect parents' insights and instincts. I have not covered every point in this review because I would be going on forever. So if there's anything else you want to chat about, please reach out. Reach out to me either in the show notes or on my website or at my email or send me a message. One of the aspects of this that I did not include is the review of different tools to assess ankyloglossia. I didn't touch on the fact that they say there is no problem with lip tie or buccal ties, which has not been ruled out. So there's so much more to this. But I wanted to start the conversation here. Again, you can find this on my blog, tonguetieexperts.net/blog, where I have this information in written form and the references are there that you can click on. Also want to mention that our Professional's Guide to Tongue Tie is a direct response to this in so many ways. If you're looking to learn more, if you're a new IBCLC who is really confused by what the AAP has said, and you're thinking that maybe you shouldn't be looking for tongue ties in babies, or it's shooken your confidence in any way, our Professional's Guide to Tongue Tie in the Breastfeeding Infant is the antidote to that. You'll find community with us. You will get credits. You'll know the latest and the most up-to-date evidence-based information related to this topic and gain confidence and help the families who are definitely more confused than you are and looking for information, because the repercussions and the waves coming from this that I've heard about are not good. Share your stories with me, the good, the bad, and the ugly. I'm here for you. Thank you so much for being here today. As always, thank you for all you do for families in your care. You're the best. Thank you so much for listening to this week's episode of the Tongue Tie Experts podcast. Check out the show notes for useful links about the topics we discussed and for ways to follow us on social media. Please subscribe to us on your favorite podcast app. And if you enjoyed listening, we'd love it if you'd rate, review, and share with your friends and colleagues. Thanks so much. Bye-bye.
Find out why less is best with the Light Scalpel Carbon Dioxide Laser. The Light Scalpel Carbon Dioxide Laser offers many benefits and advantages when compared to traditional surgical methods for both patients and surgeons. Some of those benefits and advantages include less bleeding, less swelling, less discomfort, less infection risk. The laser is less invasive and less time is required to maintain a bloodless surgical feel. The lightweight, ergonomic handpieces and flexible fiber of the Light Scalpel laser allows for enhanced precision with pinpoint accuracy. Light Scalpel's wavelength permits the selective removal of only a few cells at a time if needed. To learn more about the benefits of Light Scalpel laser surgery, please visit www.lightscalpel.com. Light Scalpel, advancing flexible fiber CO2 lasers since 1991.